We start the third session of this first day of our Congress, which is online and on-site. So we have people attending the Congress in our room and also people attending the Congress online. So I have to say hello to everybody. I know that there is a big difference of hours between the presenters. Will be a real pleasure to have international participants in this international congress. Our first presentation is Professor Chabbra from India, and I will give the floor to Professor Chabbra with the following presentation: emerging stimulation technologies in spinal cord injury care. Dear Professor Chabbra, if you can share the screen, it's okay. We can see the presentation. Only the microphone to be open. Okay. The floor is yours. Welcome. Thank you so much for your presence in our Congress.
Good evening. I hope you can hear me loud and clear.
Yes, we have sound. We have the presentation. Everything is okay.
Right. Thanks for the opportunity to be able to present. Today, I'll be presenting on emerging stimulation technologies in spinal cord injury care. We all know that spinal cord injury is a life-altering catastrophic event marked by disruption of ascending and descending neural pathways, resulting in permanent deficits in motor, sensory, and autonomic function. Beyond profound disability, spinal cord injury carries significant socioeconomic burden also, and the current management is focused on surgical stabilization, pharmacotherapy, and intensive rehabilitation. It often yields limited restoration of function, particularly in complete lesions. It's not just the patient who suffers, the family and caregiver burden is immense, other than the economic costs and societal and healthcare strain. Despite continuous research and development, which is going on throughout the world in the field of spinal cord injury, neurological prognosis is dismal in complete injuries. So the emerging stimulation technologies seek to overcome limited restoration of function by directly modulating spared spinal and peripheral neural circuits, enabling re-engagement of motor networks as with epidural and transcutaneous spinal stimulation, and restoration of essential autonomic functions as with diaphragmatic pacing, Brindley sacral root stimulation, and cardiac pacing. Harnessing these novel modalities promises a paradigm shift towards personalized multimodal rehabilitation strategies that address the full spectrum of spinal cord injury deficits. So we have various emerging stimulation technologies which are available, and we will discuss them one by one briefly in the time available to us. We all know that standing and walking are highly desirable goals of spinal cord injury individuals. Activity-based locomotor training is the only established practice to enhance recovery because there's no significant neurological outcome per se. Epidural spinal cord stimulation delivers continuous or patterned electrical impulses to the spinal cord. There have been various animal studies which showed that significant motor recovery can take place with combined spinal epidural electrical stimulation and activity-based training. They noticed stepping-like movements on epidural stimulation in a study, and in another study, in 2 human studies, they noted voluntary control of leg movements. Independent stepping and intentional overground walking was noticed in other studies, and an unexpected voluntary motor control without spinal epidural electrical stimulation was reported in one of these patients after epidural electrical stimulation. These studies suggest that spared structural connections at the site of injury exist, which were previously functionally inactive, but now may be able to modulate the excitability of the sensory motor networks below the level of injury. Plasticity in the local spinal circuits and or the descending pathways with axonal sprouting may result in voluntary control of leg movements observed even without spinal epidural electrical stimulation after epidural stimulation for a while. However, these clinical trials have been mainly case reports, and there has been no randomized controlled trials per se, so no high level of evidence in this regard. And so we decided to conduct a study on recovery of motor function of lower limb by epidural stimulation after spinal cord injury, a pilot clinical study, and this was published last year in the Journal of Spinal Cord Medicine. This was a single-arm prospective pilot study, and as far as we are aware, the largest number of subjects in any epidural stimulation trial so far. There have been some on surface stimulation that is different than epidural stimulation, as we will talk about later. The aim was to establish the role of spinal epidural electrical stimulation in improving the motor abilities of spinal cord injury individuals, the functional status and recovery of neurological function in these individuals. It was a prospective clinical trial approved by the various regulatory authorities, and all the subjects provided a written as well as video informed consent. Age group 18 to 65 years, stable medical condition, AIS A, B or C, non-progressive spinal cord injury above T10, at least 6 months post-injury, and having undergone a comprehensive rehabilitation program with the neurological recovery having plateaued were the inclusion criteria. There were a host of exclusion criteria also in these patients. So basically, we implanted a 16 electrode array over the midline of dura mater at L1 to S1 spinal cord level, that is T10 to L1 vertebral level, after the position was confirmed by a direct nerve stimulation. Then the wide leads tunneled subcutaneously, were tunneled subcutaneously and connected to a surgical stimulator placed subcutaneously in the anterior abdominal wall. After the procedure, spinal mapping was carried out to identify the right electrodes, which when stimulated at the right frequency and amplitude and pulse width, they created the desired movements in the desired muscles responsible for standing and stepping. The neuroplasticity boost, which was provided by the thoracolumbar epidural stimulation, was coupled with motor relearning by task-specific functional training in order to have a synergistic effect to have the desired results. So these therapies included locomotor training and task-specific exercises, and the therapies were personalized, so customized rehab was crucial for optimal recovery. Everyday training sessions lasting 3 hours a day were given with the spinal epidural electrical stimulation turned on, with settings for standing, weight bearing, stepping and overground walking. Trials were also conducted to look if the motor achievements were sustained when the stimulator was turned off. So the safety outcome measures were the intraoperative complications of blood loss, cord or dural injury and anesthesia-related complications. There were early and late post-operative complications were documented. The primary outcome measures of efficacy included ability to stand with control of full weight bearing, ability to coordinate stepping, and ability to walk without assistance. Secondary outcome measures included improvement in the AIS of at least 1 grade, or a change from baseline of 6 points in total Asia motor score, or a change in Asia sensory examination with the stimulator on and off. Any voluntary movement by additional muscle groups not included in INSCI was also documented, as was walking index of spinal cord injury, spinal cord independence measure, and urodynamic study to assess bladder function. So there were no intraoperative or early postoperative complications noted in any of the subjects. All of these participants were unable to stand, step, or walk without assistance before the recruitment. With epidural stimulation, 4 subjects gained better control of standing, full weight bearing. and 4 subjects were able to coordinate stepping on a treadmill, and 3 were able to walk without knee braces with epidural stimulation. Objective functional outcome measures such as whiskey and skim showed significant improvement, and the trial could be implemented successfully. That is, the desired recruitment could be achieved within a defined period with procedural adherence and participant compliance. So this is a table which shows the demographic details, level of injury, and the duration of injury, and the neurological level of all the participants. So we could conclude that spinal epidural electrical stimulation is a safe intervention. Locomotor training with spinal epidural electrical stimulation improves the motor abilities and functional recovery of persons with chronic spinal cord injury. A larger prospective study with more subjects needs to be done to draw a definite conclusion, and seems to be feasible using the protocol, outcome measures, and recruitment strategy of the pilot study. So, buoyed by the success of our pilot study, we have not only decided on a phase 2B study, but also simultaneously started a cervical epidural stimulation study, which we are in the process of publication at the moment. Here, the electrode array is implanted in the cervical region after confirming the desired position with direct spinal cord stimulation and connecting these through leads to a stimulator in the abdominal wall. So I will give a couple of case studies which will show the proof of concept of this technology. So this was a 31-year-old male, had a road traffic accident followed by weakness in lower limbs, an AIS-B T6 level, and he presented to us 6 years after the injury, and his neurological level had remained the same despite aggressive rehabilitation program, and even though he was able to do all activities of daily living and had functional improvement after the injury. He was a retired Air Force personnel. So we implanted an epidural stimulator, and these are the epidural stimulator parameters which have been documented as we do in each case. And you can see how pre-operative, pre-procedure motor power was 0 and gradually improved post-operatively, such that he was able to walk on a treadmill initially, but then now he has quadriceps power even when the stimulator is switched off. So he has shown voluntary improvement. He can do parallel bar standing without braces with stimulation. He started walking up parallel bar and now walks with a walker with gradual recovery. So neurological recovery coupled by functional recovery 6 years after the injury and with plateaued neurological recovery is proof of concept of this technology. Similarly, for cervical epidural stimulation, this 26-year-old female, a makeup artist who had a road traffic accident followed by sudden loss of power in both upper and lower limbs, C5-6 complete cervical spinal cord injury. You can see that after the injury, there was significant motor deficit in the upper limbs and there was no sensation beneath. She had undergone anterior cervical discectomy and fusion elsewhere. We planned for a posterior fixation because the construct was failing. She underwent rehabilitation. There were no successful satisfactory results. We planned for epidural stimulation after a trial check, and you can see the epidural stimulator in place other than the circumferential fixation which we can see, and you can see that she had gradual improvement in motor power with the stimulator on, and she was able to get back to activities of daily living and pursue her profession of makeup artist. even doing that in another patient who also had a complete C2 level injury, as we will talk about subsequently. So other than epidural spinal cord stimulation, we talked about transcutaneous spinal cord stimulation. The advantage being that it is non-invasive and delivers electrical stimulation through the skin to modulate spinal networks. And there have been a lot of trials in this regard, and a few of these have become FDA approved and are available in the market. But after detailed discussions with people who propagate this also, and we were also part of a trial, we feel that the epidural stimulation may have better results since they stimulate the spinal cord directly. These are some studies which document enhancement of respiratory function in cervical spinal cord injury. We participated in this international clinical trial using the SCONE device for bladder neuromodulation, and we contributed patients to this study which had key inclusion criteria and exclusion criteria, and the manuscript is in the process of being published in this regard. So in our editorial in the Journal of Clinical Orthopedics Trauma, in the virtual special issue on advanced spinal cord strategies, we with Michael Failing, we could document that this is technology with great potential, and we are going to see a lot of it in the future. We also did a literature review wherein we concluded that the literature is still in its infancy with no large-scale randomized trials and different studies using different protocols in a wide range of patients. You all have been using functional electrical stimulation for a long time, and it has been used in spinal cord injury also, as you are aware about. And this is also well documented in the literature, and it is used not only for restoration of movement and function, but also for rehabilitation therapy on mechanically ventilated patients, improving the outcome in these patients. Similarly, another electrical stimulation strategy is transcranial magnetic stimulation, which could be invasive or non-invasive, and the non-invasive one is being used largely. The magnetic field induces electrical current in the cortical neurons. The target areas of motor cortex, dorsolateral frontal, prefrontal cortex, and supplemental motor area is there, and it's being used for depression, neuropathic pain, stroke rehabilitation, and spinal cord injury motor recovery. And this has shown early results of studies have shown that it has good results, and we are sure we will see a lot more interest in this field and a lot more publications in this field with a great potential in the future. Similarly, you have brain-machine interface, which is a direct communication pathway between the brain and external device, like a computer or robotic limb, or it can be the person's own limb. So you have a brain signal acquisition, you have signal processing, and you have effector output. So it could be invasive bone-machine interface or a non-invasive bone-machine interface, the non-invasive being EEG-based and the invasive being intracortical electrodes-based. And the applications are in the field of restoration of movement, in paralysis, neuroprosthetics, and neurofeedback training. So there have been studies which have been published. These are early results of early studies, mainly case reports in this regard. Now, what in patients who have a high spinal cord injury or other neurological issue and have to be on a ventilator? So we have a promising technology called diaphragmatic stimulation. Um, which results in improvement of outcomes in these patients. The precondition is that you need to have an intact phrenic nerve. Because if the phrenic nerve has a lower motor neuron kind of injury, rather than upper motor neuron injury, then the reflex arc is not maintained and the procedure will not be successful. So there are implantable phrenic nerve pacing, direct diaphragm muscle stimulation, transcutaneous electrical diaphragmatic stimulation, and transvenous phrenic nerve stimulation. So we have been doing the diaphragmatic stimulation since quite some time now. We implant a pulse generator. First, we do a trial to ensure that the diaphragm is stimulatable. Then implant electrodes in the diaphragm where the diaphragm is best stimulatable, and then we connect it to a stimulator which is placed outside. And you have to again control the parameters such that you have best results in these patients. So you have not only reduced or eliminated need for mechanical ventilation, you have improved speech, mobility, and quality of life, fewer hospitalizations due to respiratory infections, and it is cost effective over long term. So we published our first few cases in this journal where we showed the results of diaphragmatic stimulation, and basically, as I mentioned before, we stimulate the diaphragm and see if it is stimulatable, and then implant electrodes where it gets stimulated the best. The device is unfortunately not freely available in India. We need to import it every time we need to implant it, and it is expensive as well. You can see the stimulator here in the picture to the right. And the ventilatory function improves over time in these patients, and this has been well documented in the literature also, and it is a standard of care now in USA, FDA approved, and they're using the technology also to shorten intensive care unit stay in other pathologies as well. So there may be the main limitation is the high cost procedure, but it has great potential with the future lying in wireless stimulation systems and integration with brain-computer interface as such. Now, to restore bladder, bowel, and sexual function, you have the Brindley stimulator, which has been in the market for a very long time. You basically stimulate the S2 to S4 nerve roots, and you have an intradural electrode array, implantable pulse generator, and external controller. And then, as we talked about, we need to find the right parameters, stimulation parameters, wherein it can work. So you can see that there is an implantable stimulator and the S2, 3, 4 electrodes which are implanted. And so their studies show that there can be voluntary bladder emptying with post-void residuals less than 100 ml, and significant reduction in catheterization frequency and urinary tract infections where results are not ideal in that the catheterization cannot be left aside. But there's also improved continence, independence, and quality of life metrics. And this has been in the market for a very long time. So the published literature also talks about 4 decades experience. Unfortunately, the company decided to stop its production because the sacral root was sacrificed in the procedure, and resulting in sexual function being affected in some patients, and people thinking of a great future on stem cell and other regeneration techniques. There was a drop in demand, but still there are a lot of people who want it, and we are trying that the company starts the production again, or some other company produces this. So again, in our editorial with Michael Fairlings, we talked about the great potential of this device. Cardiac pacemakers are also used in spinal cord injury, especially during the severe dysautonomia in the acute phase, where bradycardia and cardiac arrest could be seen in these patients. And this is also well documented in the literature, the usefulness of using the cardiac pacemaker. There is a great future direction in research with biomarker discovery, advanced neuroimaging, and next generation devices which are there. I want to end my talk with a case overview which demonstrates beautifully how a combination of emerging stimulation technologies improves the outcome in individuals, and in this case, a 12-year-old child who went to the park to play, and the swing malfunctioned. She fell down and had a C2 level complete injury. You can see there was no movement in the upper or lower limbs. She came to us 8 weeks after the injury with a cardiac pacemaker having been implanted in the previous institution to take care of the cardiac dysautonomia. But the odontoid had not been fixed, and at 8 weeks in this child, it was still unstable. And many people would say go posteriorly and fix in such patients. We chose to fix anteriorly despite the patient presenting at 8 weeks, because we wanted to retain the rotation, which is so very vital at the C1-2 region in patients on a wheelchair, and especially with a high level of injury. The MRI, you can see the edema ascending up to the brainstem with the C2 level injury. And we fixed the odontoid. The post-operative period was uneventful. Her uncle is a translational scientist in US, wanted to take her to Brazil for low-level laser therapy. We offered epidural stimulation. They accepted, and we put in an epidural stimulator. And we started exercises trying to engage the child with virtual reality exercises, so that with the games she engaged in exercises better, and we adjusted the amplitude, frequency, and the design. And then they wanted her out of the ventilator, C2 level injury, stimulation trial, and once it was successful, we found the diaphragm was stimulatable. We imported the diaphragmatic stimulation from and we got the procedure done, implanted the electrodes, and see, she came off the ventilator. Now for 7 months she's been off the ventilator, and she with the epidural stimulator she continues to improve and has reasonable improvement in activities of daily living, and is reasonably back. She comes to us twice in a week to continue with the rehabilitation, and is pursuing school also. So this is a wonderful example. If you can see here, when we switch off the stimulator, I'm sorry, I think we missed out on that slide. So if we switch off the stimulator, there is no power in her limbs, but with the stimulator on, she has reasonably good power in the upper limbs for her to do the activities of daily living. So with triple stimulation, with a cardiac pacemaker, with a of cervical cord injury. So the carry-home message is that stimulation technologies are revolutionizing spinal cord injury care. by targeting dormant spinal circuits to restore voluntary movement, autonomic function, and respiratory capacity even in motor complete injuries. Epidural and transcutaneous spinal stimulation demonstrate compelling clinical outcomes when integrated with functional training, enhancing motor recovery and independence. Personalized multimodal neuromodulation strategies, including FES, TMS, BCIs, and diaphragm pacing, offer tailored rehabilitation solutions across the spectrum of spinal cord injury impairments. Ongoing innovations and clinical trials underscore a paradigm shift from compensation to restoration. Spinal cord injury is no longer a static diagnosis, but a field of evolving possibility. Once empowered, individual journeys begin, enabling them to live life to the fullest, face it, embrace it, defy it, and conquer it. Friends, sooner or later you realize that real fulfillment comes only from helping others. All of the rest is just temporary. Friends, let's join hands to make life for persons with spinal cord injury across the globe happy, meaningful, and worth living. Thank you for your patience. If there are any questions and if there is time, I'll be happy to respond to. You're muted, I think.
Yeah, I have sound.
Yeah, I can hear you now.
Okay, so dear Professor Chabbra, first of all, thank you very much for your presence in our Congress. It's very honoring your presence. Was an enjoyed moment for us to have your presentation. Very inspirational presentation. So thank you very much. I will let some questions at the end of the session because maybe there are
Sure.
some minutes we can spend together.
Sure.
Now I will invite Dr. Deepa Sundareswaran, if I spell correctly the name, also from India, to have a presentation about the community-based rehab models. Dear doctor, if you can hear us and can share your screen, the floor is yours. Thank you.
Dr. Chabbra? Can you hear me, Dr. Chabbra?
Yeah, this is Dr. Deepa who needs to give the talk now.
No, that's fine. One question to you. You had shown us that you have done 3 implants, right?
Right.
So how much it would have been costed?
Yeah, I talked about the expense being a limitation in this patient. So
No, that's fine, but it's still
yeah,
I would like to know.
it's the diaphragmatic pacemaker by itself costs $22,500 US, and
Okay.
the epidural stimulation costs around even though it's around $14,500 US, we get from the company at 10,000. But these were under research, the epidural stimulation. The diaphragmatic stimulation is a standard of care, so we could charge from the patient. But the epidural stimulation, we did it free for the patient under the research trial.
Okay, thank you. Thank you very much.
Thank you also for the question. Thank you also for the answer. Thank you. Dr. Deepa, if you are with us, you can share your screen. Thank you.
Hello. Good evening. Can I start?
Yeah, yes. If you,
Okay.
yeah,
One second. I'll just share my slides. Are you able to see my slides?
Yeah, it is perfect. We can see the slides and hear you very well. Thank you.
Okay, fine. At the outset, I would like to thank Dr. Constantin Munteanu and the organizing team for having invited me as a speaker for this conference. And a warm good evening to Dr. Chabbra and Dr. Shivlal here. So nice to see you online, sir. So with that thing, I'd just like to talk about here. I'm going to speak on community-based rehabilitation models. So definitely, and I always believe in this, like, if you can believe you can and you are halfway there. So definitely. So that's how in rehabilitation, however challenging, however difficult it is just believe that is going to carry us forward and we will be reaching what we really want to do. So if we can really look into what exactly is community-based rehabilitation. So it's a strategy for disability inclusion and empowerment within the community that we are working in. So basically, it is developed by WHO in response to lack of rehab services in low-income settings. So one of the major focus when we are talking about community here is we need to focus more on the participation, which is very essential. Inclusion is the key, and empowerment. So with these three things is the main focus of community-based rehabilitation. So we talk about a lot of inclusion we are talking about, but are we really at including them? So CBR focuses more on inclusion. The more we include a person, the more they get empowered, not just the persons with disabilities and the family members and the caregivers also. We need to empower them as well. So basically, we have to equalize the opportunity and we need to include them in encourage social participation more and more. So with this three things as the main focus, that is the participation, the inclusion and empowerment. So if you can look into how CBR evolved and what CBR exactly is currently now, there has been huge shift and changes in the whole idea of CBR in terms of, I'll be discussing about the models, everything has really changed. So if you can see right from 1970s, we're having this CBR model, but it is more medically focused and it was delivering services to those with low income areas to comprehensive and it was considered as a right-based strategy for persons with disabilities. So basically the rehabilitative techniques were transferred from the specialist to the family members. Then it started slowly shifting and focus on community development, social inclusion and upholding the human rights. So if you can look into, there's a beautiful CBR joint position paper from 2004. It's a very beautiful thing that it talks about this transition from way back then in 1970 to 2004. So if we having that in mind, but why do we need CBR? So all of us wonder, there are a lot of hospitals are there, a lot of institutions are giving care to the people with disabilities. So the question here that arises here is, why do we need community-based rehabilitation? So one of the main reasons is 10% of global population, they live with disability. And when we talk about institutional rehab, again, it's not really affordable and they do not have much access to the institutional rehabilitation too. So that's when we need to consider, yes, CBRs could be the main choice. Then sometimes what happens mainly is for all of them to, as I talked about affordability, the cost is very high and urban concentration. So only the people from the urban background can go to the institution, avail the services, rehabilitation services. What about the other people who are living in the rural areas, in the community where people can't reach them? So that is another main reason for CBR is again the social stigma and the exclusion that exists there. So these are the main things why we need to focus on community-based rehabilitation. So when we look at these things here, these are the enablers of community-based rehabilitation. So one, within the person, that is the intrapersonal, the person with the disabilities. The intrapersonal again could be the person with your healthcare professionals. Then interpersonal is a communication between the person with the disability and the family member, communication between the healthcare professional and the person with disability and the caregivers. Next level, we move on to the institutional level. Everybody need to interact, whoever is taking care of the person and the caregivers. Then with the community level, we need to address it. When it comes to community level, it will go beyond the extended family. It include the people who live within the community. There can be some communities we have who are the leaders or heads of the particular regions. We need to involve them as well. And then definitely we need to have policies which is there. So policies that would favor community rehabilitation, what things need to be done, what are the facilities that can be provided. So these policies, so this is what the enablers of CBR could be. So what are the main target that we are focusing on by giving community-based rehabilitation? One, foremost, accessibility. Yes, we are going to make rehabilitation accessible to everybody. So that is something which we can, definitely it is going to be affordable. It's not going to be very expensive or costly, as is the case of institutional-based rehabilitation. And community participations. Everything when we involve the community, I think definitely the key to success is much, much higher. The rate is much higher when you're involving the community participation. So these are the three main targets of community-based rehabilitation. So if we can look into this community-based rehabilitation, who all do we liaise with? What do we actually need when we have to institute community-based rehabilitation? Of course, we have the healthcare professionals are there. Then we have the local organizations and the assets, because I have found when we involve the local organizations, because they know everything, they know the nuances of what will work there, what will not work there. So involving the local organizations and assets, it gives a great potential. And there is a community rehabilitation facilitator who is there. So we need to interact with them, liaise with that person. We have a community rehabilitation assistants. Of course, the individual and the family members are there. And what I feel is very important when we do community-based rehabilitation is to have a database. Sometimes what happens, we focus more on in the institution-based rehabilitation, we believe and we make a database. But what about having a database of those who are receiving community-based rehabilitation, who are they in need? So that is when the local people who are there, who are the leaders or heads of the particular region, they are really helpful. So this is being facilitated by the facilitator and the community rehabilitation assistant, because they give us the data, they compile the data, and data is there. So it will be easier to take it from there on. So if we can look into the CBR models, basically, as I said, it's evolved from 1970s to 1980s, where it was a pure medical law service delivery model that existed. And later, through the 1990s, it expanded and it became a participatory rehabilitation model. So current thing, if you see in 2000s, is a rights-based and the empowerment model. So I was citing the 2004 joint position paper. So it shifted from the service delivery to more holistic community development approach. So this is the key points, where did the shift take place? So if you can see, I will just put the models, a medical model, which primarily focused on the impairment and the treatment. And the professionals, whatever the healthcare professionals would say, that was only practice then. So, and that was the earlier forms of CBR. And then we shifted to the social model, where we were focus was removing the societal barriers that existed. Then disability was actually started seeing as a social construct. And definitely through the social model, we are promoting inclusion. Then we have the rights-based model, where we based on UNCRPD. It emphasizes on equality. Yes, a person who has got an injury or any disability has right to avail services. They have to be treated equally. Of course, the human rights, policies, and legislations. Next, the participatory model, where this is where we are involving both the community and the family members are actively involved. So, and here we have the bottom-up approach, and there are sustainable outcomes with this participatory model. Then the neighborhood model. So maybe there is a resource center in the community and another center. He trains the persons how to deal with persons with disabilities as well as the family members. And in due course, this again becomes another center, satellite center. Then inclusive developmental model, where it's a current global approach where we were focusing on inclusion. So basically, it's disability is included in the mainstream development programs. So then we have the district rehabilitation scheme models. So in India, actually, it was launched by Government of India. So, and this really works very well. Every state, they have the districts, and districts are district rehabilitation centers where comprehensive rehabilitation care is being provided for persons with disabilities. So this is the core model of CBR metrics, if you could see. As I highlighted before, inclusion is the key, participation. It gives opportunity for self-advocacy, equal opportunities, accessibility, and sustainability, where the domains we focus on health promotion, prevention, medical care, rehabilitation, and assistive devices, education, the livelihood, where we focus on skill development, self-employment, financial services, employment, and social protection. In terms of social, where we focus on the relationship, personal assistance, promote culture and arts, recreation, and access to justice. And in empowerment, we try to help them to build the communication, utilize the resources available in the communities, like social mobilization, involve the political people. Political participation is important. Have little groups as self-help groups where can help us. And then disabled people's organizations really help us. So this whole thing, when we focus on health, education, livelihood, social, and empowerment, so that these are the areas that we need to focus on when we consider a CBR core model. So when we look into when we're looking at how far CBR is really helpful, what is the evidence for it? So if we can look into this 2025 articles, it really talks about major components where health component was most dominant. So, and social participant empowerment were less emphasis, indicating a medically oriented approach in this particular study. So it actually focused on the need for balanced implementation and stronger policy support for inclusive development. So in 2023, if we can look into it, where human rights, social inclusion, and access to justice. And so this is when it actually talked about CBR is actually a rights-based and policy-driven model. Then in 2025, a scoping review on CBR concludes that CBR models improve quality of life and participation. So basically here what I highlighted, the basic matrix of CBR, the WHO CBR matrix is being widely used for intervention planning. So it needs standardization. So in India, if we can talk about rural India, community-based mental health is being focused on, and a lot of studies have been done. So these are the major advances in CBR. The shift to community-based inclusive development, which is called CBID, which is more taking place nowadays. And definitely we need to integrate with the national policies. We have the digital CBR program, tele-rehabilitation, mobile-based monitoring, where we look beyond rights-based approach based on the disability rights framework. So the disability right here, we talk about the 2016, the rights of persons with disabilities. As per the Act, it talks about accessibility, it talks about inclusion, it talks about employment for persons with disabilities, the education for the persons with disabilities. So we have an Accessible India campaign here. So where we focus more on how essential and how important it is to focus on accessibility for persons with disabilities. All government offices, malls, everything they say it has to be accessible for a persons with, and they have the accessibility guidelines as well. What are the guidelines need to be followed? So these till now we've seen how far CBR is extremely useful for persons, but then few things else. So what happens is there is variation in implementation quality. The way we are going to implement CBR, the quality varies, and somehow there are no lack of standardized protocols are there. And we need stronger research designs when we want to really talk about CBR. Yes, it is definitely useful. So main things with the CBR model, I would like to say it's based on the need of the person. So we need to do a needs assessment. Then capacity-based scheduling need to be done, which is very essential. Identify the capacities of individual people, and then you need to schedule accordingly. So we need to look into the experience of success or pleasure as a motivation from them. And instinctively, we need to understand what they really want, what is their mind, because here we're not only talking about the architectural barriers they may be facing in the community, we do focus on the attitudinal barriers as well. So how they are dealing with such attitudinal barriers that they have. Maximizing the use of community resources, integrate them together, and of course, definitely it has to be culturally relevant, and we need to be flexible when we go to implement CBR. So in summary, I would probably say, like, it is actually community-based rehabilitation is driven by the heart and is directed by the need. It's guided by science and is imbued with wisdom. So that's something which we need to keep in mind. So as we saw from medical, it has gone to right space inclusive development model, which is definitely it's going to be accessible, it's going to be sustainable, and it has to be socially meaningful to the person. That is very important. So as an occupational therapist is what we actually focus on, like turning hopeless into hope, can't into can, and impossible into possible. So these are my references. With that note, I'd like to say thank you to everyone who's listening there. So any questions, you're most welcome.
Dear Dr. Deepa Sundareswaran, thank you very much for your presentation. It was very understandable by the participants. I think it was very good. Thank you so much. Because we have some time problems, we have to go on for the next presentation. And I will invite Professor Yadav from India also to have the next presentation, multidisciplinary team members and the type of rehabilitation models in India. Dear Professor Yadav, you are ready.
Hi, good evening.
Yes.
Yeah, please tell me.
Yeah, if you are ready to make the presentation, will be okay.
Yeah, I'm ready.
Yeah. Please.
Do you want me to present now?
Yes, if it is possible. Thank you.
Okay. Thank you so very much. Anna bhai.
I know the time is late in India, so this is why I was thinking that it's better to have your presentation now. So this is.
Yeah. Can you see me now? See my slides?
Perfect. I can see you, I can hear you, and your presentation is on the screen. Maybe if you make it full screen.
Yeah, at the outset, I would like to thank Constantin for providing me this opportunity or this platform to deliver a talk on the multidisciplinary rehabilitation team and what rehabilitation model we practice across the country in India. In next 15 minutes, I'm going to take through, the overview of the multidisciplinary rehabilitation teams, the rehabilitation models practiced in India, and what's the vision by 2030 about the rehabilitation program. As we all know, like the composition of the team, which include the medical professionals, like physiatrists and other medical colleagues, who helps to assess, diagnose, and manage the patient treatment plans with its rehabilitation process. Because the rehabilitation process is a dynamic one, so it needs to be assessed, reassessed, to know like that what goal needs to be formed again to have the better recovery. And allied health colleagues, like which include therapists and the psychologists, dietitians, the peer counselors, and the patient itself. So as I've told you, the PMR physician, they are the team leader which lead the rehabilitation team, and they help to diagnose and they treat the conditions which is affected by the brain, spinal cord, nerves, bones, joints, and muscle and tendon. Therapies, they improve through physical function, mobility, and the strength. The occupational therapy, that helps to improve the daily activities independently, who trains the patient for self-care, walk, leisure activities and also adapt the environment to use the assistive devices. The speech and the language therapy that address the communication, the solving difficulties, problems, and that help to patients to communicate effectively and to eat safely, so that there is no problem with the respiratory complication because of the, like if the food goes into the windpipe. Rehabilitation nurse, they are into the education program and which educate the caregivers, maybe the family members, that what are the recovery plans and what are the the complication which may occur because of the the disease process and how they can be taken care of. The psychologists who they assist the and treat the emotional, cognitive, and the behavioral challenges amongst subset of the people. The other colleagues in the team are the prosthetist orthotists who have the crucial role to restoring the mobility, function, and improve the quality of life for such patients. And the dietitian who provides the medical nutrition therapy tailored to individual patient needs. And they also educate the patient for healthy eating habits. So here you can see the rehab team is the integrated team which take care of holistically the patients to have the better outcomes, and evidence and the impact are self-explanatory, that it reduces the disability and the complication and it improves functional independence and better participation in quality of life, and at the same time it is cost-effective and sustainable outcomes. And like that, how multidisciplinary teams makes a difference, because it's a coordinated team care pathway which ensure the holistic biopsychosocial management and which plan early discharge or reduce down the length of stay in the hospital, which really take care of the the financial burden on the family, and it also bridges the medical care and the rehabilitation services. And this rehabilitation program which works in tune with the international classification of functioning disability health, like from impairment to activity and activity to participation finally into the community. These are the few models which are being practiced widely in India, like institutional based rehabilitation, which provided in the hospital and the rehabilitation center, which gives the structured medical and therapeutic care, and it is best to be in the complex condition where need the various specialist support. Secondly, the community-based rehabilitation, Dr. Deepa has already explained, and which she has rightly pointed out, that it empowers the person with disability within their own communities, and this program can be initiated at their doorstep. Whereas the home-based program, which is therapy and support at the patient's home, which is convenient, comfortable, and family-centric, and which promotes independence in daily life. So now another area, like most of variety of the NGO, they are into the field now for the rehabilitation programs. So they basically offer the rehab services like to underdeserved populations who they cannot reach to the hospital because they live in the far-flung, the rural setup, or maybe, the finance is the big burden on them, so that they cannot reach to the institutions. So they offer the therapy and training and education advocacy at their doorstep, and it also bridges the gap where government services are limited. So, but their different models are practiced across, but the goal is one, that is better recovery for all. So certain there is the advantages and the disadvantages, like institutional rehabilitation, based rehabilitation, as it is a structured environment, 24/7 medical supervision, having access of the specialized equipment and the therapies, and ideal for the complex cases and who they need the intensive care program as well. But it has got certain disadvantage, like it is an isolated environment, detachment from the family and the community, this higher cost. Where the community-based rehabilitation, Deepa has already pointed out, is a reintegration into the society, helps to reintegration in society. There is involvement, family and community, and it's cost-effective, and it promotes the independence, life skill, and participants at the same time in the home setup. But there are certainly disadvantages, like limited access to the specialized equipments and the therapies, which is not possible at their home environment and depends on community resources and family supports. So sometimes people who they are already engaged in the community rehabilitation program, they may not be happy with these kind of things because the money is not provided to them. So they'll quit the program in between. So there is again the dependency increases. So and there is a lack of consistent professional supervision, because either the supervision can be done through chatting on the mobile phone or tele rehabilitation program. Yeah. So resources and infrastructure constraints are big problem, like setup like in India. So nowadays the technology taking the first place for the training programs, policy reforms to driving improvements in the wider reach to the rehabilitation services across the country. So like WHO has already set the vision 2030 for rehab policy, and India is signatory for United Nations Convention on People with Disability, People's Right with Disability. So we are the part of it. So India has taken the key priorities in this context to have the universal access, integrated health system. There is a workforce development, because like the rehab workforce is very minimal in India, so that there is a government has developed the workforce development program also. Then more and more focus on the technology and innovation through tele-rehabilitation or AI-based functional assessment and the robotic and assisted devices used. So the government is also trying to focus on the quality and standard nationwide. The rehab guidelines that are in the process to build up, and also the social inclusion, like to more and more to have the community-based rehabilitation program. And these could be only optimized through the multidisciplinary rehabilitation, teamwork, scaling rehabilitation in India across rural and the urban areas, integrate the institution-based and the home-based care, so that there is a continuous care of the disabled across all the domains, like in the institution or community or in the home. Finally, at home, integration, then expand access through the skilled workforce and the collaborative research. The technology has become taken a 4 seat for the future rehabilitation program, in which the tele-rehabilitation AI innovations are being developed now to have the better integrated rehab services across the rural and urban area. So another thing which is big in its place now, the policy and the funding initiative to develop supportive policies and secure funding to enable wide reaching and the consistent rehabilitation service across. And in this direction, there is a training to provide ongoing education and skill development for professionals. There is a training and the capacity building programs also being taken place. If we go on like that, how we can build up the inclusive or empowering the disabled. So the government has made the national policy for person with disabilities, and later on, this rights of person with disabilities came in year 2016, where from disabilities, which was initially in 2006 policy was 8, now it has been taken gone to the 21 disabling condition to have better mandate for accessibility and inclusive education and the legal safeguard for the disabled people. So there is also schemes for social security and economic empowerment are in place, which includes like Accessible India campaign to have barrier-free accessible place, workplace, or maybe like recreative place, or maybe the education. And the Nation Action Plan for the skill development for people with disability is also into the place. And there is also schemes to provide financial assistance on the law, like interest, or maybe the aids and appliances to improve quality of life, independence, and the social inclusion, which is given free of cost to people who they have got low middle income. And also the Mental Health Care Act had come into the place in year 2017. So which protect the right of person with mental illnesses and promotes community-based rehabilitation and the right to live with the dignity with the disability. So other, like the people who they're vulnerable, like, acid attack people or who have got the, burn injuries. So there are some schemes are also in place to help those kind of people, which are previously not really too much used across. Apart from this, now few of the private hospitals, they are trying to have the transitional care program. Like one of the centers is SCH in India, which was initially healthcare at home providers. This is crucial for successful rehabilitation. It prevents readmissions, reduces complication, and ensure continuum of care after the hospitalization of the patient. And it also tailors the rehabilitation program and designed to meet the individual patient needs and also make the rehabilitation accessible and convenient with state-of-the-art facilities at very low cost. Now, Government of India is also following the same kind of module to use, because like the hospital ICU care is very, very expensive, and sometimes like the beds are not available. So in that case, the young guy who got injury needs the intensive care, but because of the bed occupancy, like they are not being taken care of. So in view of that, they are also going to form the transitional care hospitals, so they can be taken care of in between. So most of the people can be treated at a very low cost, and the insurance companies also coming forward to help such schemes now. So before I conclude, like the take-home message is like multidisciplinary rehabilitation is essential for optimal recovery, and the physiatrist leads coordinated patient-centered care, and there is need to integrated team approach to ensure the holistic outcomes. And the model has to be always scalable, like from institutional to the community to the finally to the home-based program. And at the same time, we need to address the urban-rural gaps and to fill the workforce shortage gap. And technology will be the technology-driven will be the future of the rehabilitation program. Dr. Chabbra has already mentioned that what is the role of technology into the rehabilitation program. And the continuum of care, it should be acute from the hospital to the community. So it should be have, like right intervention, right time and right team. It will take the from acute care to the community care. Thank you very much. If you have any question, I'm happy to answer that.
Thank you very much for the presentation. I have a small question. If you can tell us more about the link between the universities and the domain of rehabilitation. First, if there are some connections, links, and second, if there is also a difference between public and private, let's say, rehabilitation sectors, or if the private sector is also developed to the level of the public level. Thank you.
Thank you very much.
Okay. If there are other questions from the panelists, if not, we thank very much for the presentation of Professor Yadav. And go on with the next presentation. My colleague will help me.
Thank you. Thank you, Dr. Constantin. Thank you very much. Have a great evening.
To our colleagues from India for the amazing work on technology that could have a potential benefit in the treatment of spinal cord injury, and we are looking for larger scale studies that can demonstrate that beneficial. And also thanks for the two presentations of the India rehabilitation models and their role in the community, the integration of disabled people, and also for improving their quality of life. And next, I am pleased to announce the next presentation, the next two presentations, clinical presentations, developed by a research group from Moravia Faculty of Medicine under the leadership of Associate Professor Nistor-Cseppento Carmen. a distinguished colleague that is present every year in our congress, a very interesting presentation like this two case presentation, and I am inviting the Dr. Gherle Anamaria for the next presentation, evolutionary features in a case of tetraplegia, predominant left hemiplegia following severe traumatic brain heteroaggression.
Thank you very much. Let me just share my presentation. If I can share. Okay. Can you see it?
Yes, everything is perfect. Only to go to the full screen.
Okay. Can you see? So my name is Gherle Anamaria, and together with Professor Carmen Czeppento and Professor Liviu Lazar, Professor Cevei, I prepared two case reports that I want to share with you on this occasion, and I hope you enjoy and we can learn something from them. So the first presentation is entitled Evolutive Features in a Case of Tetraplegia with Predominant Left Hemiplegia Following Severe Traumatic Brain Injury due to Heteroaggression. So to set the frame, I want to make a short introduction for everybody to understand better the pathophysiology and the definition of the traumatic brain injury. So a traumatic brain injury is defined as an alteration in brain functioning or other evidence of brain pathology caused by an external force, either through a strong impact to the head or by objects that penetrated the skull and damaged brain tissue. Examples of source of injury include road traffic accidents, falls, assaults, gunshot wounds. Also, traumatic brain injury should be differentiated from other types of acquired injuries to the brain, such as tumor, stroke, due to the significant differences in mechanisms, treatments, and outcomes between traumatic and non-traumatic injury. Also, TBI, traumatic brain injury, should be differentiated from the term head injury, which is defined as a blow to the head or laceration and may occur without causing injury to the brain. In this slide, I want to discuss a little bit about the severity of the injury because it's important to establish that early on in the rehabilitation treatment plan in order to set a time frame for recovery and estimate the global and functional outcomes. Coma duration is also linked directly with the injury severity and outcomes. Traumatic brain injury is often categorized as mild, moderate, or severe. The Glasgow Coma Scale is the gold standard for primary initial assessment of severity of injury based on level of consciousness. Injury severity is also defined by the duration of coma and the severity of the symptoms. Post-traumatic amnesia, for example, long duration of coma, are often associated with a poor prognosis. Pathophysiology, from a pathophysiological point of view, the TBI are complex processes. They consist, first of all, of a primary injury that disrupts brain tissue and function at impact. Second of all, a secondary injury through multiple biochemical cascade that propagates cellular dysfunction and lead to cell death. And third, there's a chronic degeneration, repair, and regeneration process that occurs over the long term after the injury, and repair is associated with the pathophysiology of the traumatic brain injury. So there are three phases in the pathophysiology of the traumatic brain. So stepping forward to the case report, the patient that I want to present is called Mrs. S.R. She is 63 years old and she was admitted on the 5th December 2025 in our clinic, approximately 2 months after sustaining a polytrauma due to heteroaggression. If you wonder what happened, she was beaten by her nephew, unfortunately. And that's resulted in a severe traumatic brain injury with a right frontal intracerebral hematoma extending into the internal and external capsula associated with perilesional edema, midline shift, mass effect on the right lateral ventricle. She had also a nasal pyramid fracture, a thoracic trauma with a hemopneumothorax that was drained. The patient medical history relieves a prolonged ICU stay of approximately 2 months and 1 week, with a fluctuating clinical course marked by repeated infectious relapses. She developed bronchopneumonia in the ICU with Klebsiella pneumoniae, Pseudomonas aeruginosa, Staphylococcus aureus. She also had a urinary tract infection with multidrug-resistant Klebsiella. And these complications negatively impacted her clinical and functional status. The patient also developed septic shock shortly before the initial transfer attempt to our department, but that was subsequently resolved under triple intravenous antibiotic therapy. So the indication for admission, she presented to our clinic with the following complaints. She had tetraparetic motor deficit, more pronounced on the left hemibody. She had severe impairment of standing and gait, severe limitation in activities of daily living, dysphagia and mastication disorders. She had speech impairment. She had pain all over her body, but mainly in the left part of the body. She had major cognitive deficit. You will see later on in the slides the scores, the MMSE and the quick aphasia battery scores. She had anovesical sphincter dysfunction and was very agitated. The clinical examination, the general clinical examination revealed that the patient was not orientated. She didn't know where she was. She had severe psychomotor agitation and incoherent speech, severe dysarthria, left central facial paresis. Her pupils were equal, reactive to light. The skin was pale, desquamated. She had also central venous catheter in the left internal jugular vein, which she kept when she was admitted to our department, and we kept it because it was just freshly put. She was stable from a cardiorespiratory point of view. Her mouth didn't open very much. She had microstomia. The tongue was very coated. She had constipation. And the feeding was possible through a PEG, to a gastrostomia. Urination also was possible through a catheter Foley that was present. From the local examination point of view, at the first admission, we see that the patient has left hemiplegia, so no motor control in the left part of the body, not in the shoulder, not in the elbow, not in the wrist, so motor control 0. She had a Wernicke-Mann attitude with a flexion posture of the elbow fingers, contractures, mainly in the plantar flexors. The spasticity graded on the modified Ashworth scale was 3 out of 4. Mainly the forearm wrist flexors muscles were affected, and also the left lower limb extensor were affected. But the upper limb was more spastic. She had a right hemibody paresis with a muscle strength of a 4 on the MRC scale, and a 3 out of 5 for the lower right limb. The passive mobility was very painful and reduced for the hips, the knees. In the left knee, she had an instability, and the knee was tender to touch and to palpate. The meniscal part was very tender. Also, she had pyramidal syndrome on the left hemibody. So the functional Examination revealed that she was unable to perform transfers. The standing and walking was impossible. She was unable to maintain sitting posture, required 100% assistance for bed mobility and sitting. She was completely dependent for Adele's self-care and feeding, and she had a MMSE score of 5 points out of 30. So she has severe cognitive impairment. If we look at the standardized scales, international standardized scales, she obtained 21 points on the FEM scale out of 126, which also suggests complete dependence from another person. On the Bartel index score, she obtained 5 points out of 100. The FAC scale was 0, so she was bedbound. We couldn't transport her to the gym in the first week. Even in the second week, we couldn't transport her. So we had to do the exercises to her bed. On the trunk control scale, she obtained 0 points out of 100. And on the PENS, the SPASM scale, she obtained 1 point out of 4. So she had 1 spasm per day. So the objectives were tailored for the 3 phases. So the initial phase, the intermediate phase, and the final phase. In the initial phase, we had the following goals: maintenance of vital functions within normal values, prevention of nosocomial infection, pressure wounds, deep vein thrombosis, pulmonary embolism, and pulmonary complications, maintenance of vital functions, adequate nutritional support, improvement of sleep, pain, speech, and swallowing, treatment of urinary infection and constipation, improvement of motor control in the left upper limb, prevention in the intermediate phase. We moved on with the following objectives: prevention of musculotendinous contracture, enhancement of exercise tolerance, because she had 0 tolerance to effort, re-education of motor trunk control with improving trunk stability, transfer training, relearning transfers. And in the final phase, we concentrated more on improvement of the ability to cross the body midline, to obtain coordination, balance re-education, to re-educate the activities of daily living, reduction of spasticity, of course, and last but not least, gait re-education. The medication that she took was, her chronic medication was levetiracetam, anti-epileptic drug. So you see this high dosage, but the neurologist, our neurologist from our team, gradually decreased it until she reached, I think, 250 twice per day. She now has perindopril for high blood pressure, amlodipina, lioresal for the spasticity, baclofen, but it's not such a high dosage, zolpidem because she cannot sleep, gabaran for the neuropathic pain, a very small dosage in the evening. As neurotrophic medication, the neurologist prescribed her cerebrolizine, 10 milliliters, 2 vials per day for 10 days. And also we put her on NurAid, 6 pills per day for 3 months. And the NurAid was introduced in the intermediate phase. And that made quite a difference for her when she starting to gain control in the lower limb. You will see in the movies, in the next movies. So the therapeutic interventions that we did was for her to have a rigorous hygiene and skincare. We used anticoagulant prophylaxis, anti-decubitus positioning, regular repositioning, respiratory physiotherapy, expectorant treatment because she was loaded with secretions. We did speech therapy, swallowing, phonation rehabilitation. The nutrition was still made via PEG, but you will see in the next slides that she regained swallowing and she regained speech. She was able to feed herself. She regained some of the Adele's. But the PEG, we still kept it because she was not psychologically prepared to remove the peg, and we kept it a little bit longer because of the desire of the patient to not remove it. We did the bowel management, pharmacological management for spasticity, neuropathic pain, neurotrophic support, urinary infection control, circadian rhythm regulation. So the rehabilitation program consisted of individual kinetotherapy, first 2 weeks in the room of the patient, but afterwards we took her to the gym, occupational therapy in the gym, Andago, which you will see it's a dynamic support treadmill, not treadmill, dynamic support exoskeleton, virtual reality for cognitive problems, Vibramove for sensibility problems and rehabilitation, Voitha she did for the trunk control stabilization, functional electrical stimulation for the tibial anterior muscle, logopedy, and psychological counseling. In this order, but through her process, we exchanged some of them. So I want to show you some videos with her. This is the patient in the Andago. We did a gait training using the Andago robotic device. Let me show you. So this is her, I think at approximately in the fourth week of admission. So you can see that she's not already stable. The Andago supports her weight with the orthosis that you see there, but she's capable to initiate active movement in the hip area, which is important as a first step. Here you can see her in the occupational therapy room. We are working with her hands. Here also in the occupational therapy room, our physiotherapist is learning her how to climb stairs. He's telling her how to initiate the steps. You can see here that the motor control is only present in the hip area, but we took advantage of that and tried to put load on the lower left limb. You can see also there that she is wearing a drop foot orthosis to help her with the drop foot. Okay, let's move forward. Here she's in the kinetotherapy in the gym. We started early on with the rolling to help her strengthen the core and the trunk. So she was able, after the 4th week, to do the rolling by herself. These are very important exercises for the hemiplegic patient to initiate the motor control in the trunk. Here also in the kinetotherapy, we load the left upper limb to improve motor control in the elbow, in the wrist, to give input for the brain, and also balance and coordination for the trunk. Also in the kinetotherapy, she was very motivated to do all the exercises, very happy when she could do it. Here is the first moment when we try to initiate steps. And we were very happy when she could do this. This was a milestone for her because she couldn't move at the initial time. T0, she couldn't move at all the leg. So here in the last phase, you can see her walking with a tripod cane, with a drop foot orthosis, almost independently, not independently using a tripod cane, but even so, okay. And here she's in the final phase. Here you see her at the wall doing the virtual reality for the lower limbs, for the trunk. So the functional outcomes that the patient had, in the first month of admission, the gait and standing was impossible. The transfers were possible with approximately 100% from another assistance from another person. She was not able to maintain a sitting position at the edge of the bed. Left upper limb, she had no active movement, motor control absent, both proximally and distally. Left lower limb, motor control absent. She responded to the questions within the limits imposed by the dysarthria that she had, the severe dysarthria, with a yes or no types of responses. Moving on to the third month of admission, now she was able to maintain sitting position at the edge of the bed. She only required 50% help for performing the transfers. The left upper limb, motor control partially present proximately, but still absent at the elbow and the wrist level and the fingers. The left lower limb, motor control was present proximately, but at the knee and the ankle was absent still. The pyramidal syndrome present on the left side, proprioceptive sensory disturbances she had in the left hemibody. Moving to the 5th month of admission, you can see her now walking in the hallway of the hospital. She was able to achieve standing. Ambulatory was independently over short distances. For longer distances, ambulation is performed using the assistance of a tripod cane. Transfers now she performs independently. The left upper limb motor control is present approximately partially present at the intermediate level and still absent distally. For the left lower limb, motor control is present proximately, intermediately, and absent distally. Here I put her to the Armeo spring device, even though it's an exoskeleton, and even though I know it has the patient needs to present motor control for the elbow and the wrist. I still wanted to see if we can achieve something with this device. I had a discussion with the physiotherapist and he told me, no, she will not do it. No, she cannot do it because she has no motor control in the elbow and in the wrist. And I tell him, okay, let's just try, because the brain sometimes has powers that we don't understand. And using the visual feedback of the screen, maybe the movement is easier. And so it was, because she could perform the exercise at the Armeo spring device. I will show it. Okay. So the rehabilitation progress is quite clear. You can see that from an objective point of view, on the trunk control scale, she had 0 points, and in the final, she had 100 points. On the Bartel index score, in the initial phase, she had 5 points, and in the final phase, she had 35 points. The FAC scale revealed 0 points in the beginning, and in the final stage, she used the tripod walking stick. On the quick aphasia battery scale, initially she scored 0.2 points, and in the final stage she scored 5.6 points out of 10 maximum points, and the mini-mental state evaluation was 5, very low in the beginning, and in the final stage it's now 24. So quite normal now. The conclusion of the case highlights the complexity and severity of traumatic brain injury, underscores the importance of a comprehensive multidisciplinary rehabilitation approach. Despite an initially critical clinical and functional status, the patient demonstrates significant neurological and functional recovery over time, as evidenced by improvements in motor control, cognitive function, and in independence in activities of daily living. The favorable outcome was achieved through a personalized stage rehabilitation program integrating kinesiotherapy, robotic-assisted gait training, functional electrical stimulation, speech therapy, and cognitive rehabilitation. This case emphasizes that even in severe traumatic brain injury, meaningful recovery is possible when early, intensive, and interdisciplinary rehabilitation strategies are implemented. So here she is with her partner that helped her a lot. The partner was with her every step of the way, and he has a great deal of credit in her rehabilitation. Thank you for your attention.
Thank you for your presentation. It was a wonderful presentation. I see 2 hands raised, so maybe Dr. Deepa Sundareswaran and also Mr. Shivalal Yadav have some questions for the presentation. Please.
Can I ask one question to Anamaria?
Sure.
Yeah, like my question to you is, because you had shown the improvement, like were they statistically proven or were just like clinically observed? There are two things, right?
Yeah.
So
She had
hope you
also,
got my question, no?
sorry, I didn't understand the first part of the
First part
question.
was like, was it statistically shown improvement or just like clinical observation, right?
Clinical observation through standardized scales that we perform on her. But she's just one case. So statistically, we didn't do a case report or a case studies or something like that. I think it's possible to make a statistical approach, but I think we should have at least 6 patients to do a six patients case report study minimum, I think.
Yeah, two, like, but I would like to congratulate you, like very nice presentation. Thank you so very much.
Thank you.
Okay, in this case, I have to close the session now because there are some issues regarding the welcome cocktail to be resolved. So it will be a book presentation just now in the front of the in the hotel. So we invite you to this book presentation. And after that will be a specific moment of the welcome cocktail related to a great band which will be present in our conference. So thank you very much for this session. Because of the time we have to end here and see in the front of the. Thank you. Bye bye.